I thought I would begin with a case history entitled Abnormal Liver Function Tests and Lipid Profile in an 8-year-old female with childhood obesity. So is this non-alcoholic fatty liver disease? Next slide. So at the time she was first seen, she was 7 years old, white female who had been complaining of abdominal pain for 4 months. She was seen in another pediatric gastroenterology clinic and was treated with H2 blockers like Pepcid, which didn't help. She was also treated for constipation, again, with no effect. And at that time, it was noted that she had no weight loss, vomiting, diarrhea. There was no blood in her stool. And she was also noted to have abnormal liver function tests when they did some general blood work. And at the time, she was also noted to have an abnormal lipid profile. However, the rest of her labs were normal. Next slide. So as you can see, these were her blood tests that were done at the time. And you can see that her ALT and her AST, which are 2 liver enzymes, were elevated. In children, these are usually considered to be normal if they're less than 25. Her alkaline phosphatase, total protein, and albumin were normal. And then in pink, you can see her lipid panel. And the results highlighted in yellow show that these were abnormal. So her cholesterol was elevated, her LDL was quite elevated, and her HDL was low. And this was a fasting blood sample. Next slide. So on examination at that time, she was noted to meet the definition of childhood obesity as her BMI was greater than the 96th percentile for age. Her abdomen was non-tender, and the person who examined her at that time noted that that the liver and spleen were felt to be normal in size. And so the plan was to do an upper endoscopy because of the abdominal pain, some blood work, as shown here, and an abdominal ultrasound. Next slide. So if you can see, these are her growth curves. So these are very important in children. And on the left-hand side is her height, which you can see is not over the 95th percentile. And then on the slides on the right are her weight and her BMI. And as you can see, her BMI is greater than the 96th percentile. Next slide. The ultrasound that she had done was normal. The other blood work was negative for viral hepatitis, for autoimmune hepatitis. She was noted to have a normal level of alpha-1 antitrypsin. Her CBC was normal, and metabolic screens like serum amino acids and urine organic acids were normal. Next slide. Next slide, please. So she underwent an upper endoscopy, and these are pictures, these are photographs from her upper endoscopy. On the far left upper square, this is the normal esophagus, and then the normal, on the next photograph over is the antrum, which also appeared grossly normal. The bottom left shows a picture where we look up at the top of the stomach, and that black structure in the middle is our scope coming from the esophagus into the stomach. So that area was normal. And then the one on the lower right shows the duodenum, which also appeared grossly normal. Next slide. So we usually do biopsies when we do upper endoscopies in children, and a biopsy of the esophagus was normal, a biopsy of the stomach was normal. And the duodenum showed the presence of what the pathologist called histiocytic aggregates with pale brownish cytoplasmic pigments that can be compatible with ceroid-laden histiocytes or macrophages, which are a type of cell. Next slide. This is just a picture from her pathology. The green arrow points to these ceroid histiocytes that are not normally present in the duodenum, but the pathologist wasn't quite sure what to make of them, and the gastroenterologist who did the test didn't know what to make of them either. Next slide. So she went on to have, because of the abnormal lipids, a familial hypercholesterolemia gene panel, which was negative. And because of the elevated lipids, she was sent to see an endocrinologist. 6 months later, the pediatric endocrinologist started her on a statin, which is a lipid lowering drug, and her liver enzymes, the AST and ALT, remained persistently abnormal. Next slide. 10 months later, she was referred to liver clinic because of the persistently elevated liver tests, and I saw her at that time. I noted she was not jaundiced. Her bowel movements were normal. She had infrequent abdominal pain, but it was still there. She had no nausea, vomiting, or fever, and no itching. She had no history of ever having received a blood transfusion. She had no tattoos, but she did have pierced ears, which were done at Claire's. Next slide. And on physical examination, she had no signs when I looked at her of chronic liver disease, such as red palms or clubbing of the nails, or spider nevi, which are little red dots that you can find, multiple ones in patients who have chronic liver disease. I did note when I examined her abdomen that it was soft, it wasn't tender. However, her liver was soft and I could feel it about 8 centimeters below the rib cage, which is enlarged. Her spleen, I couldn't feel her spleen, and therefore it wasn't enlarged. Next slide. And I did blood tests at the time I saw her, which showed the abnormal AST and ALT again. Her GGT, which is an enzyme that represents the bile duct cells in the liver in children, and it's much more representative than the alkaline phosphatase. So that was mildly elevated. And her lipid panel was also abnormal, again with her LDL being high, even though she was on a statin, and her cholesterol was still elevated. Next slide. So based on this, the abnormal lipids and the fact that her LDL was quite high and her liver enzymes were abnormal, I did a test for lysosomal acid lipase activity, which showed she had a level of 0. And therefore, based on this, I felt the diagnosis was cholesterol ester storage disease, or what we now call lysosomal acid lipase deficiency. Next slide. To confirm this, and also to determine how much scar tissue she had in the liver and how far her liver disease had progressed, she underwent a liver biopsy as seen here. And the blue areas that you can see on this slide represent scar tissue. And normally there should be no scar tissue in the liver. Next slide. And we also took a small piece of liver at the time of the biopsy and sent it off for electron microscopy, where the pathologist can look inside each individual cell. And you can see here, which is typical for patients who have lysosomal acid lipase deficiency, there were, you can see fat droplets, which are the blue arrows, and the pink arrow points to cholesterol crystals, which we usually see in this disease. Next slide. So our patient went on to have genetic testing, which showed that she was a compound heterozygote with a mutation in exon 2 and another mutation in exon 8. The parents were checked, and you can see she inherited the exon 8 mutation from the mother and the exon 2 mutation from her father. Next slide. So what is lysosomal acid lipase deficiency? It's an autosomal recessive disease, meaning you need one abnormal gene from each parent. It is a lysosomal storage disease, and it's due to mutations in the lysosomal acid lipase gene, or the LIPA gene. Next slide. So there is a clinical spectrum of disease with lysosomal acid lipase deficiency. And Moishe Wollman, back in the 1950s, first described what is now known as Wollman disease. And this is really the infantile onset of lysosomal acid lipase deficiency, where you usually have absent or less than 1% of normal activity. This presentation is rare, about 1 in 500,000. Next slide. The other end of the spectrum is cholesterol ester storage disease, which can occur in older infants, children, and adults. And usually there is some residual lysosomal acid lipase activity between 1 and 12% of normal. And the incidence of this seems to be higher at 1 in 300,000. And this was first described by Donald Friedrichsen in the 60s. Next slide. As you can see from these population studies, lysosomal acid lipase deficiency has been reported in almost every country. So Africa, Australia, Austria, Brazil, Canada, the United States, France, so Europe, the Middle East, and Asia. So it's really, one can be born with the disease really anywhere in the world. Next slide. So what does lysosomal acid lipase do? Well, it's responsible for the degradation of cholesterol esters and triglyceride. So if you have deficient lysosomal acid lipase activity, what happens is you get accumulation of cholesterol esters and triglycerides in the lysosomes, which is an organelle within the liver cell. This occurs in the liver, adrenal glands, intestine, and the macrophage monocyte system. So you get accumulation of cholesterol esters and triglycerides in these organs. Next slide. So just to go back a bit, Wolman disease, in terms of the clinical manifestations, the onset usually is within the first few days to months of life. These patients usually present with vomiting and profuse watery diarrhea. They may or may not be jaundiced, and they usually have abdominal distension, typically as shown here in the next slide. Next. Patients with Wolman disease will often have enlarged lymph nodes, enlarged tonsils, an enlarged liver, and a big spleen. Next slide. And in the gastrointestinal tract, because you have lipid deposition in the lining of the small intestine, and usually the jejunum is more involved than the ileum, patients end up with severe malabsorption, and so they usually present with failure to thrive. Next slide. And typically patients with Wolman's disease will also have calcifications found in the adrenal glands. As you can see with the arrow in the right upper hand photograph, you can see the white areas, the dense white areas that kind of look like a V. So that is calcifications in the adrenal gland. And you can also see it on a plain film in the left hand micrograph. Just under the diaphragm there, you can see two patches of more intense white, which represents calcification in the adrenal glands. Next slide. And untreated Wolman disease is uniformly fatal, as you can see from these curves. Usually most patients die before a year of age. Next slide. Cholesterol ester storage disease, on the other hand, next slide. As you would expect with an autosomal recessive disease, males and females are equally affected. The average age of onset for these patients, rather than early infancy, is between 4 and 6 years of age. And the average age range at onset can be anywhere from less than 1 to 68 years of age. Next slide. Patients will often present with diarrhea, malabsorption, weight loss, failure to thrive, abdominal pain, like our patient, vomiting, and they can even have gallbladder dysfunction. Next slide. They will often present with hyperlipidemia, showing a high cholesterol, a high LDL, a low LDL, and high triglycerides. One can see that they will often have lipid deposits in the skin. As shown on the right-hand side, these whitish areas represent xanthomas or lipid deposits. They can also have premature atherosclerosis. Next slide. And as you can see here, this is a young patient with lysosomal acid lipase, and you can see the little white dots near the vertebrae on the left-hand side, and around the thoracic aorta, you can see the white dots. These represent calcifications and atherosclerosis with lipid deposits. Next slide. In terms of the liver manifestations, most patients will present with an enlarged liver, and about 3/4 will also have a big spleen. They may be anemic, and they may have a low platelet count. Sometimes these patients can develop gastrointestinal bleeds secondary to esophageal or gastric varices as a result of scarring in the liver and portal hypertension. They may also have jaundice or may develop as their liver disease progresses, ascites or fluid in the abdomen. Next slide. And if you look at the liver is usually yellow and greasy if you look at the cut surface, and it's usually due to small droplet fat. And again, this is from the storage of triglycerides and cholesterol ester in lysosomes of the hepatocytes and macrophages and Kupffer cells within the liver itself. Next slide. And you can see in about 72% of patients will develop hepatic scarring or scar tissue in the liver, and about 30% will go on to develop cirrhosis. And as you can see, the white areas in the bottom photo show the areas of scar tissue that are occurring in these patients, and they almost form round circles, which is indicative of cirrhosis. Next slide. What are the causes of death in patients who have cholesterol ester storage disease? Well, patients may have accelerated atherosclerosis, so occurring at a young age. They may develop coronary artery disease, strokes, and they may have end-stage liver disease and present with liver failure and complications of portal hypertension. Next slide. How do you make a diagnosis of lysosomal acid lipase deficiency? Next slide. So when we want to think about the diagnosis, again, I think the key is if you have an AST and ALT that's mildly abnormal, that's typical for lysosomal acid lipase deficiency. The GGT alk phos are usually normal. The bilirubins may be normal to increase depending on how well the liver is working at the time. And synthetic function, that means how well the liver is working, is usually preserved early on. And so the PT-INR and the albumin and bilirubins, which represent how well the liver is working, are usually normal, but they will become progressively abnormal as the liver disease progresses. Next slide. And the lipid biochemistry usually demonstrates an elevated cholesterol, elevated triglycerides, an elevated LDL, and a low HDL. Next slide. And this slide, I think, is very interesting because it shows that the LDL patients who, the lysosomal acid lipase patients who have LDLs measured, they're usually very high. And you may see elevated LDLs in adults and pediatric patients who have non-alcoholic fatty liver disease. But the elevation and the degree to which the elevation occurs in these patients is much less than in patients who have lysosomal acid lipase deficiency, as shown with the top blue bars. Next slide. Imaging studies may be helpful. Getting an abdominal radiograph may show you adrenal calcifications. An ultrasound may show you an enlarged liver spleen. CT scan and MRI. MRI may show the fat in the liver. Next slide. And a liver biopsy may be helpful in the diagnosis, or at least for staging of the scarring if you already have the diagnosis by measuring lysosomal acid lipase activity. Next slide. So probably the easiest way is to measure lysosomal acid lipase enzyme activity in the blood. This can be done with an actual blood sample or by drop testing. And of course, genetic testing is also helpful. Next slide. So what about treatment? Next slide. So in years gone past, medical therapy was used. So a low-fat diet. The use of statins was controversial. Some people felt it helped. Other people felt it didn't. Some people have tried cholestyramine to bind the bile acids, and some people have tried azotimib along with a statin. And I think it's really hard trying to ask a child not to eat at McDonald's and so on, and to have a low-fat diet. Next slide. People have tried hematopoietic stem cell transplants, and with the idea that you would get engraftment of donor stem cells and macrophages and thus get secretion of functional lysosomal acid lipase, which would then result in the repair of the primary metabolic defect. Next slide. However, this did not reverse the adrenal involvement. There was still a high risk of mortality, And in fact, in a couple of reports from Unier and Jones, you can see mortality was close to 100%. And most of the time, these patients died of hepatic complications. Next slide. Liver transplantation has also been tried for those patients with end-stage liver disease and who have developed liver failure. However, 39% developed atherosclerosis and cardiac disease post-liver transplant. And in fact, you can get recurrence of lysosomal acid lipase deficiency because it affects the macrophages, which are found in the liver. And therefore, you can get recurrence of storage of cholesterol esters and triglycerides within the transplanted livers in about 61%. Next slide. So in 2015, there was a report published in the New England Journal of Medicine about a phase 3 trial of cibilipase alpha, which is enzyme replacement therapy for this disease. Next slide. And you can see on this slide, the mean change in the alanine aminotransferase, or the ALT. In the first part of the graph, you can see in the yellow circles, or at the top, this was a placebo group who did not receive treatment with cibilipase alpha. And the lower line shows patients who were treated with cibilipase alpha, which is the enzyme replacement. And you can see that the ALT came down to pretty close to normal. And then at 20 weeks, approximately, patients were allowed to go into an open label period. And you can see those that were on placebo, once they started on cibilipase alpha, they had a similar response. Next slide. And if you look at the low density lipoprotein, which is quite elevated in patients who have lysosomal acid lipase deficiency, again, you can see a fall in the LDL in the treated group and not any real fall in those who were on placebo until they were placed on the cibilipase alpha, which is the top line. Next slide. And if you look at high density lipoprotein, which is usually low in patients with lysosomal acid lipase, you can see the HDL levels start to come up on treatment with cibilipase alpha with no effect in the placebo group until they started the open label period where they were given the medication, and you can see the HDL levels start to rise. Next slide. So in summary, next slide. Lysosomal acid lipase is a soluble lysosomal hydrolase. And in patients with Wolman's disease, there's absent to less than 1% activity. And in cholesterol ester storage disease, patients usually have some residual activity, but not enough to prevent disease. It is autosomal recessive and it's due to mutations in the lipid gene. Next slide. And as a result, patients will accumulate cholesterol esters and triglycerides, which result in liver disease. Because of the high cholesterol, high LDL, and low HDL, patients will develop atherosclerosis. You can have other organ involvements besides these, and death, however, is usually due to liver or heart disease. Next slide. Milder forms of lysosomal acid lipase may be undiagnosed or misdiagnosed because people don't think of it. So we do think that the incidence may be much higher than 1 in 300,000 that was found in that one study. So the key points to remember, I think, if your patient has abnormal liver tests, they have a high LDL, and remember to check to make sure they're not on a statin, but if they have a high LDL and a low HDL, which is adjusted for age, then one should think of testing for lysosomal acid lipase deficiency. Next slide. Thank you for your attention.